Hello everyone, welcome back to Learn Anesthesia Basics. I'm Dr. Kavyamita. Today we'll be discussing about fetal circulation and transition at birth. Before we go into the topic, why do we need to know about fetal circulation and transition at birth? Because during obstetric anesthesia, we'll be the few people to be in first person in contact with the neonate and the mother, and it is very important for us to know about the fetal circulation and what happens immediately at birth, and how important it is for the neonatal resuscitation to be within 1 to 5 minutes, early neonatal resuscitation. So let's see what how fetal circulation is different from the adult circulation and what happens at birth. Fetal circulation starts with, let's start this with placenta. From placenta, the maternal blood goes through umbilical veins to the fetus. These umbilical veins travels through to the liver where the blood is pooled into portal sinus. From the portal sinus through portal vein, they get added into inferior vena cava. This is portal vein and it gets added into inferior vena cava. Some amount of blood from the umbilical veins directly goes into IVC, bypassing the portal sinus through ductus venosus. The saturation of blood in umbilical veins is approximately 80%, and IVC before the umbilical vein blood is joined, it is 25%. And the saturation after the blood enters the IVC, here it is 67%. The blood from the IVC joins the right atrium, and from superior vena cava also enters the right atrium. From right atrium, it enters the right ventricle and to pulmonary artery. From right atrium, the blood also enters the left atrium through foramen ovale. So directly it bypasses the right ventricle and enters the foramen and enters the left atrium through foramen ovale. From left atrium to left ventricle to left ventricle to descending aorta. The blood from the pulmonary artery enters the descending aorta through ductus arteriosus. From ductus from descending aorta through umbilical arteries, it returns back to placenta. So we have ductus venosus and we have ductus arteriosus. Ductus venosus is between umbilical vein and IVC, and ductus arteriosus is between pulmonary artery and descending aorta. We also have foramen ovale between right atrium and left atrium. So the deoxygenated blood enters the placenta through umbilical arteries. And the fetal circulation is the systemic and pulmonary circulation. The systemic and pulmonary circulation is parallel in fetal circulation when compared to series in adult circulation. So the extrauterine survival of a fetus will be after 22 to 24 weeks of gestational age. Why it is after 22 to 24 weeks of gestational age is because pulmonary capillaries are formed at this age, and that at 30 weeks of gestational age the cuboidal alveolar epithelium flattens. So the surfactant formation starts at 30 weeks of gestational age. Cuboidal more than 34 weeks of gestational age, there will be sufficient pulmonary surfactant. So, what happens? What exactly happens at birth? At birth, that is at term gestational age, there will be the fetal lungs are completely developed, and there will be 90 ml of plasma ultrafiltrate is present in the lungs. When when the baby delivers through normal vaginal delivery, This fluid is squeezed from the lungs by pelvic muscles and vagina. This is called vaginal squeeze. And the remaining fluid which is present after the vaginal squeeze is reabsorbed by pulmonary capillaries and lymphatics. So this is what happens in normal vaginal delivery. Respiratory efforts normally starts within 30 seconds after birth, and it will be sustained within 90 seconds. This respiratory efforts start because of mild hypoxia, acidosis, and sensory stimulation. Sensory stimulation like cord clamping, pain, touch, and noise. This vaginal squeeze is absent in cesarean deliveries. So, with lung expansion, there will be increased alveolar arterial oxygen tension, and there will be decreased pulmonary vascular resistance. This causes pulmonary arterial dilatation, which causes increased pulmonary blood flow and increased left heart flows, that is, increased left atrial pressures. This causes functional closure of foramen ovale. This eliminates the right to left shunt and establishes adult circulation. This increased alveolar arterial tension also causes ductus arteriosus to contract, ductus arteriosus to contract and close functionally. This also is helped by acetylcholine, bradykinin, and prostaglandins. So acetylcholine, bradykinin, prostaglandins also help in the closure and contracture of ductus arteriosus. So anatomic closure of ductus arteriosus happens by 2 to 3 weeks, and anatomic closure, this is functional closure of foramen ovale, but the anatomic closure of foramen ovale takes up to months. So what happens if there is hypoxia and acidosis during first few days of life? There will be persistent fetal circulation, and there will be persistent pulmonary. This causes persistent pulmonary hypertension of newborn. What happens in persistent pulmonary hypertension of newborn? There will be increased pulmonary vascular resistance. This causes right to left shunting of across the foramen ovale, causing right heart failure or right ventricular failure, and right to left shunting across ductus arteriosus, causing left ventricular failure. This again causes hypoxia and acidosis, which is a vicious cycle which happens continuously in the newborn. That's it for today. Thank you for watching. Please like, share, and subscribe.